about the arrhythmia in COVID era. Dr. Ahmed.
Okay, thank you very much. So it's an absolute pleasure to be here, and I'd like to thank you all for the invitation. So I'm going to tackle the topic of arrhythmias, and I have no conflicts of interest. So arrhythmias in the context of COVID-19, we know that they are prevalent, and the prevalence is around 1 in 6 patients. And this is based on observational data from China. And this poses a number of challenges to management of patients with arrhythmias. And I've subdivided them according to the following. So firstly, there will be arrhythmias that are associated with COVID-19. Secondly, we will have to deal with patients who have acute arrhythmias who don't have COVID. And there has been a reshuffling of cardiac arrhythmia services, both elective and in the acute setting during the COVID era as well. And finally, we have to manage patients who have pre-existing cardiac conditions. So we've already alluded to this before, but yes, myocarditis is associated with COVID-19, and patients who have heart failure with COVID-19 or have a high mortality risk. The main arrhythmias that we will expect to see are atrial arrhythmias, ventricular arrhythmias, and AV block. The management of these conditions or these arrhythmias does not differ, I would say, too much than what we would normally do for a general case of myocarditis. For atrial arrhythmias, we would focus on rate control with beta blockers as the first line, digoxin second line, and sometimes we consider amiodarone. With regards to ventricular arrhythmias, again, beta blockers would be the mainstay, and IV metoprolol acutely. And also for those patients who perhaps they're on intensive care, IV nebivolol may be quite useful. As well as we have other antiarrhythmic agents such as amiodarone and lidocaine. One important consideration is whether these patients who have ventricular arrhythmias, whether they should be considered for an implantable cardioverter defibrillator prior to discharge. With regards to AV block, the main approaches would be, as you would do with any case, treat and correct any reversible causes, so electrolyte abnormalities, etc. Isoprenaline may be a good sort of holding measure, and sometimes patients may require temporary pacing, and certainly in some cases they may require permanent pacing. So I'm going to start off with a case. The first case that I'd like to share with you is a 56-year-old patient who is known to have ischemic cardiomyopathy with an LV ejection fraction of 30% and an implantable cardioverter defibrillator. So this patient presented with a history of fever, loose stools, and breathlessness, and was found to be COVID positive on swab testing. They actually presented to their local hospital with recurrent ICD shocks. They were found to be profoundly hypokalemic, and they had actually missed a couple of days worth of their bisoprolol because they were unwell, and on assessment they were hypotensive. So this case was managed with a replacement of potassium intravenously, reinitiation of the bisoprolol, and the patient was admitted for monitoring and observation. Now, I think this is the typical type of case that we may see more of in COVID-19, and I think perhaps we may see this more commonly than myocarditis. Another example. So this is a second case of a 60-year-old patient who has recurrent syncope. They presented with fever, abdominal pain, and cough. And on that basis, they were deemed to be high risk for COVID in the emergency department. They were fortunate to have an implantable loop recording, which was they'd had that for a couple of years as they were being investigated for a syncope. And it demonstrated a 10-second pause. And on the right-hand side, this is not the tracing from the patient, but it's very similar to the tracing. And this patient was referred to us for a permanent pacemaker. Now, in view of the high risk, the fact that the patient was high risk for COVID-19, obviously we need to be more careful about our assessment of patients and selection of patients for interventions. The history that was taken found that the syncope occurred in the context of abdominal pain. And in fact, this was a recurring theme with this patient, who would always have their syncope in the context of some trigger, such as abdominal pain. They were known to have a structurally normal heart, and their ECG, 12-lead ECG, was completely normal. So the diagnosis was made of vasovagal syncope. And if we look at that trace in more detail, we can see a classic response in patients who have cardioinhibitory vasovagal syncope. At the top line, you see sinus rhythm, which with a gradual slowing of the heart rate. And in the second line, you can see gradual sinus bradycardia. And in the third line, you can see that there is a sinus pause. So this patient was not taken for a pacemaker, but was given lifestyle measures, increase their fluid intake, salt, and to avoid triggers. Now, in terms of dealing with the second problem, which is acute arrhythmias in a non-COVID patient, these arrhythmias can be tachyarrhythmias or brady, and I'm going to focus on tachyarrhythmias first. Of the tachyarrhythmias, we have atrial fibrillation, flutter, tachycardia, paroxysmal SVT, and then ventricular arrhythmias such as VF and VT. Now, the treatment of AF and atrial flutter and atrial tachycardia really in this COVID era should really focus on a conservative approach with very good rate control and optimization of beta blockers, for example, ensure patients are on anticoagulation, and try to minimize the length of hospital stay. And we should be mindful that patients who are elderly, over the age of 70, 75, we can accept a more lenient rate control strategy, which has been shown in prior studies to be as effective. So that means if over the age of 75, if your heart rate, if your atrial fibrillation with a ventricular rate of 110, that's acceptable. Patients with paroxysmal SVT, we should teach them vagal maneuvers and use that as an opportunity so that they can potentially terminate their arrhythmias without needing to come into hospital. But those who require treatment, we can use medications in the first instance, for example, beta blockers or flecainide. There is a role for catheter ablation in such patients, but really it's reserved for patients who have poor rate control associated with heart failure or those who have recurrent hospitalizations. And this is recommendations from the NHS England and Public Health England. And the NHS England have made a statement which is regarding cardiology, management of cardiology patients during the COVID era. And this is one of their recommendations. So the patient who has VF or VT, again, we would treat them in a similar manner. If they have hemodynamic compromise, for example, VT without a pulse or hypotension, then we go for a DC shock. Obviously, we have to be careful about our protection and make sure that we wear full personal protection equipment. The British UK Resus Council recommend that you can do a number of stacked shocks before commencing CPR in such patients. And that information is available on their website. So we would manage the patient in a similar fashion. We would look for and correct any reversible causes, for example, ischemia, QT prolongation, electrolyte abnormalities. And we have a number of things that we can do in terms of management, which include beta blockers, other antiarrhythmic drugs such as amiodarone or IV lidocaine, if bradycardia is the mechanism, then overdrive pacing can be very effective. If the arrhythmia is related to an adrenergic response, then sedation, intubation is usually quite helpful, particularly in patients with catecholaminergic polymorphic VT, although that's a very rare condition. We would then be looking to investigating the patients with imaging, echo, perhaps MRI scan, to try to determine the etiology of their ventricular arrhythmia. And then such patients, if they survive and they have a good neurological recovery, we should really consider an ICD as usual in patients prior to discharge. Now, there is a role for catheter ablation in the context of VT, and this is in patients who have incessant VT or VF that's refractory to medications. Okay, moving on to bradyarrhythmias. So again, as I've alluded to in the previous case, it's very important in this COVID era to evaluate the history very importantly and assess the ECG, as well as looking at the medications, electrolytes, and thyroid function, and to understand whether the patient who has this arrhythmia has evidence of structural heart disease or not. The guidance from NHS England is that if the patient has high-grade AV block, then we should go for permanent pacing. However, patients who have sinus node dysfunction, then we can take a conservative approach and defer the pacemaker procedure until the pandemic is over. But obviously, as clinicians, we need to assess that with every patient and assess the severity of the symptoms, the likelihood of severe injury, and whether they have recurrent hospitalizations. So this is a case, third case, a patient is 83 years of age who has recurrent syncope. They have a background of vasovagal syncope, but they're also known to have left bundle branch block. They had no symptoms related to COVID-19 or any contact with anyone, so they were deemed to be a low risk. This was their ECG on the right-hand side when they attended emergency department, and at that time they were pre-syncopal and their heart rate was 25 beats per minute, blood pressure of 180 systolic. So you can see the diagnosis is complete heart block. They responded well to atropine, and they were referred for an urgent pacemaker, and which was implanted. It was implanted on the same day, and the patient was actually discharged later on that day. And this is something that's quite important, that we do have the setup and the facilities to implant pacemakers and discharge patients on the same day. So I've already mentioned about the restructuring of arrhythmia services within the COVID era. And these are the guidelines that I was referring to for the management of cardiology patients during the coronavirus pandemic. Essentially, the document says that any outpatient or elective work should be deferred in non-urgent patients. And our job as clinicians is to determine what constitutes urgent and non-urgent. We should try to use remote clinics as much as possible and virtual clinics, either via telephone or video conferencing. We should be careful and selective about which diagnostic tests we use during this COVID era, and only select those tests which are going to change our management. Patients who have pacemakers, defibrillators, CRTs, or implantable loop recorders, we may be able to move towards remote device monitoring rather than physical appointments. This is something that is relatively easy to implement. And we should also have a rapid access clinic so that patients who present to the emergency department can be fast-tracked and referred to this rapid access clinic for an urgent consultation, and that at least minimizes the amount of hospitalizations. On the right-hand side here is a table that demonstrates what we should do regarding the various procedures within arrhythmia. So, for example, I've already mentioned about pacing. So patients who have symptomatic AV block should continue pacing, but defer sinus node disease where possible. Patients who, for defibrillators, the guidance is secondary prevention defibrillators, and that's including the cardiac synchronization therapy, CRTDs, should have their procedures as usual. Primary prevention devices should be evaluated on a case-by-case basis, and the CRTP or upgrades should be deferred. Patients who require generator changes, we should prioritize the ones who have end of life and those who are pacing dependent. And then regarding ablation, then they recommend only to continue ablation in patients who have malignant arrhythmias, which are defined as pre-excited atrial fibrillation in the patient with Wolff-Parkinson-White, patients who have heart failure secondary to their tachycardia, whether that's an atrial tachycardia, AF, or ventricular tachycardia, and patients who have drug refractory VT. So the next case is a 46-year-old patient who had a mitral valve repair and a Cox-Maze procedure a few months back. They then developed persistent atrial flutter, which was atypical, with a rapid ventricular rate. And as a result, they developed moderately impaired left ventricular function, and they were symptomatic. They were already treated on maximal beta blocker, and they were on amiodarone. And the patient did not have any symptoms of COVID-19 or any risk factors. So this patient we took to the cath lab for an ablation. They had an elective atypical flutter ablation, and the diagnosis was a micro reentry tachycardia on the roof of the left atrium, mediated by scar from the previous Cox-Maze procedure. Now, the ablation, we were successful and we terminated the tachycardia, and the patient was, the procedure was done in the morning, which allowed the patient to be discharged later on that same day. Now, just a note about the cath lab procedure. So there have been some changes in the way that we operate within the cath lab. And so, for example, for our ablations, we try to avoid general anesthesia and try to take a sedation and local anesthesia approach. We recommend, we use full PPE, personal protective equipment, for the first and second operator, and also for one scrub nurse. We've adapted a long line for the use of intravenous drugs to minimize patient distance for the nursing staff. All patients will have a mask, usually an oxygen mask. We try to minimize the DC cardioversion, so we plan our cases very carefully to try to minimize the need for DC cardioversions. And again, as I've mentioned, we try to do the cases in such a way that we can discharge patients on the same day. And this is following recommendations from the British Cardiovascular Society on how to manage the cardiac cath lab. On the right-hand side is a picture that's from Imperial College, showing the different types of personal protective equipment that is used. And on the bottom, we can see the FFP masks, which have a special filter that prevent the viral particle from entering and you inhaling it. And that's something which is recommended. Okay, so moving on to patients with pre-existing cardiac conditions. So this is a case of a 27-year-old patient who was a primary PCI activation. They'd had 6 days worth of fever, and the temperature was recorded at 39 degrees by the paramedics. They had a history of cough and feeling unwell, and in fact, they were self-isolating for the last 6 days. They developed acute chest pain. The paramedics performed this ECG on the left-hand side, and as you can see, there's ST elevation in V1 and V2, and they were referred to us for primary PCI. Now, the diagnosis here is actually Brugada syndrome unmasked by fever, which has been reported in COVID-19, in a COVID-19 patient. And this is something we need to consider, that patients we may see more patients with Brugada syndrome and this unmasking of Brugada syndrome by fever. It has implications for the management of patients in the acute setting and also later on. Firstly, we need to make sure the patients have aggressive control of their fever with paracetamol. They should avoid certain drugs which are listed on the brugadadrugs.org website. We may need to consider monitoring patients, inpatient monitoring, and also these patients need to be followed up at a later stage for familial screening. The Association for Inherited Cardiac Conditions, and the website is listed at the bottom there, they've provided guidance for clinicians who manage patients with inherited cardiac conditions and Brugada syndrome. And essentially, it regards to the diagnosis based on the ECG pattern of the ST elevation, coved ST elevation of 2 millimeters or more, and T-wave inversion and a right bundle branch block pattern. Depending on whether the patients have a defibrillator or not. So patients who have a defibrillator, that if they have symptoms of COVID, they can self-isolate. Patients without an ICD need to be risk stratified, whether they're high risk or low risk based on certain characteristics such as age, whether or not they had syncope, or whether this is, and how febrile they are, whether their fever is controlled or not with medications. Those are high risk really should be admitted for monitoring. The other thing that we find quite useful in such patients who have a suspicious ECG is to use a high V1 and V2 ECG to improve the sensitivity of picking up those changes, which is the type 1 pattern, which is diagnostic of Brugada syndrome. The difference between a normal V1, V2 and a high V1 and V2 is that V1 and V2 is usually placed on the fourth intercostal space, whilst the high V1 and V2 is at the second intercostal space. So I've mentioned about patients who have pre-existing inherited cardiac conditions, so things like DCM, HCM, arrhythmogenic cardiomyopathy, and patients with inherited channelopathies such as long QT. This poses a lot of challenges for us as in the arrhythmia management, particularly when it comes to monitoring the QT interval and with some of the medications that have been suggested for COVID that are known to prolong the QT. Also, we have some challenges regarding patients who are managed in a prone position with COVID and how we can monitor them with an ECG. We have challenges regarding the virtual clinics. Personally, I find it difficult in some cases to manage patients without knowing what their rhythm is, and having an ECG can have consequences. A lot of our patients already have remote monitoring from their devices at home, so this is less of a problem for us. So, in conclusion, the cardiac rhythm management during COVID remains very challenging. The pandemic is a rapidly evolving field, and in such times, the sharing of experiences and collaborations is of great value. And we should try to be flexible and innovative in our approaches to manage such patients. Thank you very much.
Thank you, Dr. Adlan. That was a great summary of all the arrhythmia and how to manage it in this difficult time during coronavirus. Now, I think in the interest of time, we'll probably move on to the next talk, and then we could have some time for question and answers at the end. So if I could ask Dr. Abu Bakr Khalil to talk to us about venous thrombosis.
Sure.
Hello.
Thank you very much.
Yes. Hi.
Yes, I can hear you. Thanks very much. Elegant presentation by Ahmed. You've raised the bar so much. For a cardiologist who's going to talk about a hematological problem. So thank you.
They'll learn something from you now.
Okay, let me see if I can do this technically, because before I try Abdulazim's help. Now, is it coming through, Abdulazim?
Yes, it's coming. Can you see it now?
Okay. Okay, so I'll let you then do the slide movement for me. Thank you so much. So I'm just going to talk about two different things, thromboprophylactis and bleeding tendency during COVID presentation. Next, please. And then quickly to the next, please. So thank you. In COVID-19, there's significant increased risk of hospital-associated venous thromboembolism. There are also other types of thromboembolism, arterial types, but I'm going to focus more on the venous side because it's more common. This is predominantly due to excessive inflammatory response during the acute phase reaction, combined with immobility and the vascular changes that takes place during this event. Lung injury in particular will lead to hypoxia, which also can trigger thromboembolic cascade. This is usually associated with significant DIC, but in COVID presentations, the platelet drop is not parallel to